All right, great. So we're in our final stretch, which is session 4. And this is kind of a potpourri of different things, including some tips and tricks, some non-pyogenic infections like TB, and then towards the end we've got some upper extremity cases. So yeah, let's start with Dr. Shah. Dr. Hitesh Shah is again a dear friend of mine. He's the professor and head of pediatric orthopedics at Kasturba Medical College in India. He was a past executive member for POSI and is a very prolific researcher, including not just, bone infections, etc., but also like Perthes and, tons of other topics. So Hitesh is going to give a background talk on non-pyogenic infections. Go ahead, Hitesh. Thank you.
Thank you, Sanjeev. Uh, from the beginning, we are listening acute osteomyelitis and chronic osteomyelitis. I move on to the next topic in non-pyogenic infection. Next slide. So I'm going to cover up the non-pyogenic infection presentation, investigation, AFib management, and management option. Next. So in this non-pyogenic infection, basically tuberculosis, brucellosis, and fungal infection. Common, will start with the tuberculosis. Is very common. Next slide. So tuberculosis is the incidence of the non-pyogenic infection is 5 to 6%, very common in the developing world, and couple of talk has been showed in subacute osteomyelitis, the infection crossing the facies as well as in developing country. However, it's not uncommon in the developed world where the immunocompromised children would be present with the liver disease or renal disease. Next. The Mycobacterium tuberculosis will be common for the infection, and it's always secondary infection. The primary site would be the lung, GI tract, cervical lymph node. The next slide, please. The commonest site is being the spine, followed by the hip, knee, ankle, elbow. It's also not uncommon to see the infection of the bone. However, in the joint, it follows the specific stage of synovitis, early arthritis, and the late arthritis. Next. Because of the differential, it's a chronic infection. The presentation and classical symptoms would be highly varied. So because of the low-grade infection, it's easily missed by the physician and orthopedic surgeon. The classic and atypical presentations are also common, and the tuberculosis is great mimickers of anything. So that if we are going to talk about the tuberculosis, always we have to keep as a differential diagnosis for the any bone and joint involvement. Next slide. So if we are talking about the symptoms of the patients, it's highly varied sites from the limb deformity of the bone and joint, pain or a pathological fracture, dislocation, arthritis, ankylosing or instability. Next slide. That's if we see about the child with the synovitis, either because of the any of the epidemiological common disease, but we have to keep in the any joint involvement. If the patient is from Southeast Asia or the Africa, always keep tuberculosis as one of the differential diagnosis. Next slide. Or the patient with the arthritis also to keep as tuberculosis child. Various condition will be also mimicker in the arthritis. The next slide. Then, and in case of the osteomyelitis, particularly, we have listened the comments on the presence of subacute osteomyelitis. Very commonest is the subacute is the tuberculosis. And if any infection crossing the joint across the facies, think about tuberculosis, rule out about do the investigation, and these are the differential diagnosis, but most important is that subacute presentation of the infection or the chronic infection, think about tuberculosis. Next slide. The most important investigation, there are many investigations depends on epidemiological presentation, but the most important and the significant would be the gene expert, because that will give about the sensitivity of the drug also. It has to be done. Now that is always routine practice to do the biopsy and the culture before starting anti-tuberculous drugs. Next slide. It's very important to understand that every case of tuberculosis cannot be managed the same way. So there are the various the variables like the age of onset, the age of the present. Next slides. Next, the age of the disease. Next, stage of the disease, the area of involvement. Next slides. Whenever is the duration after the next, whether it's a bone, joints, or the synovium is involved. That's presence of the deformity, tuberculosis, or associated with the complication, either it's subluxation, dislocation, or any other advanced complication. Next slides. If there is the goal of the treatment of tuberculosis, we need to get the painless, stable, mobile, and functional status as much as possible. For the key, next slide, for the key of the management to get the best outcome, we need to detect early and treat it early. Next slide. So the important aspect next, the most important is the medical treatment. And the one of the question in the audience was that how long we need to give the AKT or anti-tuberculosis drug. It's been said the short-term regime or long-term, but at least 12 months should be minimum for the recommendation for its WHO. Next slide. The most important four combination of four drugs, intensive phase and maintenance phase depends on the, it's in the kids, it has according to the kg weight of the child, it should be given in the morning. Next slide. So that is the main important aspect, is that the medical treatment. The question comes, is it surgery is recommended? Most likely that's only synovectomy and the debridement is enough in the most of the cases in the nights. It is a effusion or abscess. If it is not amenable, is not getting better, then only required. Most of the surgery is only for culture and histology. It can be done in non-invasive or under CT scan or under non-invasive methods. Next slide. The synovitis, how to treat with that? The patient will be given that 2 months intensive and the medical management, the rest for the 4 weeks. And as soon as after the joint range of motion is gaining, we allow the child to walk. Surgery is rarely required for synovitis. Next slide. In case of the early arthritis, again the medical management, and very rarely you need to do about the surgery. They always do the culture and sensitivity to get the sensitive antibiotics. Next slide. That's late arthritis. It's you need to get some surgery because of the mechanical malalignment and mobilization as far as always. Next slide. So we'll show you some cases of the difference of that. This is a child, 13-year-old girl present with the synovitis. It's been detected. Next slide. MRI showed the synovitis, but the ESR and CRP was higher. So child has been treated with the aspiration and gene expert was positive. Next slide. So child has been treated with attraction and mobilization. Next slide. So it's treated with the anti-tuberculosis drug and non-weight bearing for 3 months. Next slide. So this is the 3-year follow-up. It's got the complete functional spineless stable joints and the child is walking normally. Next slide. Another example of the child's that's learning point is early diagnosis key for functional status. Additional surgery is rarely required. Next slide. It's one of the example, the 8-year-old child with the presence of subluxation presented with this early arthritis. Next slide is one treated with that initial parts with the gene expert was positive, child was immobilized in the spica. Next slide. And child has got the anti-tuberculosis drug for 1 year, non-weight bearing for 3 months. Next slide. This is the child has got 1.5 year, got followed, but the movement is restricted. A child has got the sound ankylosis. Next slide. And the child has got a complete ankylosis after 7 years, but it's a painless and stable hip, although it is not a mobile hip. Next slide. So learning point is there. Again, it's a reasonable result to get the early arthritis. Next. This is the bone joint involvement of the ulnar osteomyelitis. When treated the expansion of the proximal ulna, typical features of the tuberculous osteomyelitis, not much sequestrum, not involucrum, not much periosteum reaction. This is typical of the osteomyelitis of the tuberculosis. Next slide. It's been treated with the anti-tuberculosis. This is the MRI. Next slide. It's been treated with only the next slide. It's treated with the tuberculosis. This is 1 year follow-up. And next slide. The child's no other surgery, 2 years follow-up, complete reformation of that. Next case, next slide. This is another child. This born to be next slide. The another child presented with the pain and swelling on distal aspect of the tibia. The ankle joint was normal. Next slide. The X-ray shows that across the tibia involvement. Next slide. That across the tibia involvement, MRI and CT was done, shows that the extension across the physis. Next slide. The child has been treated with the biopsy. Next slide. And this was also tuberculosis. Next slide. And it's been just put, no other incision was done. It's protected with a bow knee cast. Next slide. This is a 5-year follow-up. It's got no limb-length discrepancy. Next slide. So the important aspects of the learning point for tuberculosis osteomyelitis can cross it, but you need to follow it for the limb-length discrepancy and angular deformity in such cases. Next slide. If the time permits, I can talk on the brucellosis
Actually,
quickly.
Okay, yeah. Just like maybe go to the talking points would be awesome.
Yes, because it will be common in where the animal or the livestock farming is common. Again, it's a medical condition we can treat with the medicine. The difference between tuberculosis and brucellosis is there. It can be detected with the blood culture. It's need not to have a tissue biopsy, and it's medical treatment and treatment. Triple medical treatment would be sufficient. Very rarely it is required to do the surgery. Thank you very much. Sorry for that.
That was great. I'm sorry. And yeah, you can go to the take-home messages.
Yeah.
Go ahead.
Early diagnosis is the key.
Yeah.
Yeah. The medical management is the main sub-treatment. Most of the cases will required with medical management, but surgery is required for the mechanical malalignment or the complication. Thank you.
Okay, excellent. Thanks, Hitesh. And sorry to rush you, but we're doing good. Okay, next I'm going to call back Dr. Venkat. I think he's got a recorded talk on tips and tricks. All right, let's do it.
Hello, everybody. I'm going to talk about tips and tricks for treating the sequelae of osteomyelitis with some case examples. I will start off with this 1.5-year-old boy who had an infection in the forearm, osteomyelitis of the ulna to be specific, about 4 months back. He underwent drainage and decompression at another facility and was treated with antibiotics for 2 months. Right now, he's clinically cold. There is no signs of active infection. His bloods are normal. And if you look at the X-ray, there is clearly a gap in the ulna with about 4.5 centimeters of gap with a small sequestrum as well. So about at this time exactly, there was a publication by Dr. Sandeep Patwardhan in which they published the results of about 26 children with bone defects following osteomyelitis who were treated with non-vascularized tubular grafting with decent outcome. So we decided to do the same for this patient, non-vascularized tubular strut grafting and fixation with a K-wire. Unfortunately, probably we didn't get a good hold of this small ulnar enlarge there. So it united proximally. This is a 3 months follow-up, but distally there was a resorption of the gap and non-union. So to rescue the situation, we revised the fixation and did sort of ulnar shortening osteotomy, thinking that it might help in union as well as get the variance adjusted. But through our bad luck, the non-union persisted, and subsequently he underwent ulnar lengthening. And this is like a 10 years follow-up of the patient. The child is 11.5 years now. The ulna is short, and there is radial bowing. And I'm sure that this is going to worsen during his adolescent growth spurt, and he's going to need one more surgical procedure to get the forearm aligned well. But a couple of years later, we came across this patient who has about 7.5 centimeters loss in the ulna following an infection. About 3/4 of the ulna was missing and the radial head was dislocated. So we wanted to revisit the previous case and wanted to look what went wrong in this patient. So we thought whether the avascular bone can act like a dead bone and probably exacerbate a lurking infection. The solution which we thought about was to add biology to the fibula. And this idea originally originated from this technique of osteoperiosteal slide of the tibial graft, which we use for reconstructing the fibular gap after vascularized harvesting. So you can see that in this particular patient, there is a huge gap after harvesting a vascularized fibula. And this is a small sliver of the tibia along with the periosteum, which we take from the lateral cortex or the posterior cortex of tibia. We place it here and suture the periosteum with the proximal and distal limb. And to our surprise, we could see that the fibula is completely regenerated within a few months' time. So we believe that adding periosteum could improve union rates, and that's what was done for this patient. So we did an osteoperiosteal fibular strut grafting and reduced the radial head as well and fixed it with the K-wire. At 6 weeks, you can see that it beautifully united both proximally and distally, and the radial head was also in place. This is a 1 year follow-up of the same child. We planned for K-wire removal, and this is a 4.5 year follow-up, which shows that decent outcome compared to where we started. And we do agree that this patient needs to be followed till skeletal maturity. So we published this technique in International Orthopaedics in 2024. And the take-home message from this case is that reconstruction of post-osteomyelitis bone defects, fibular strut graft is a very good option, but an osteoperiosteal fibular strut graft increases the chances of union. Moving on to the second case, this is a 10-year-old boy who had a pain in the right knee following a fall, which was, the fever was on and off. There is no discharge. His range of motion in the knee was full, and there was localized tenderness in the proximal tibia. If you closely observe the X-ray, there is some lucency which is seen in the metaphysis, which appears to extend to the epiphysis, both in the AP and the lateral view. And when we did an MRI, we clearly saw that there is an abscess in the metaphysis, which crosses the growth plate and goes into the epiphysis like a hourglass appearance. His bloods were surprisingly normal, so probably it is a subacute infection. However, we went ahead to drain the abscess, and we know that whenever there is connection between epiphysis and metaphysis, there is a potential chance of bar formation. So in order to avoid that, we did a cement interposition. His culture grew Staph aureus and he was started on clindamycin, and this is 1.5 year follow-up. Looks like the cement has worked to some extent. There is no bar formation as of now, but however, we need to follow up the child. Looks like the cement is migrating slowly down. We have seen this patients same phenomenon in patients who have had bar excision with cement interposition. The cement tends to migrate into the metaphysis and slowly into the diaphysis, and there is again potential chance of bar formation. So longer follow-up is needed in this child. Transfacial osteomyelitis, the incidence is reported to be about 15%, and the growth disturbance rate could be as high as 13%. The median size of the total physeal damage is about 7.6%, and luckily there is no significant difference in the appearance of complication based solely on the size of the initial lesion. So the take-home from this case is transphyseal hematogenous osteomyelitis is not uncommon. The incidence could be up to 15%. MRSA and Kingel are common organisms, and they can have significant growth arrest, which is not related to the size of involvement, and cement spacer is an option to prevent growth arrest. Moving on to the third case, this is a 14-year-old boy following a road traffic accident who had a polytrauma with a pubic diastasis and the open fracture of the tibia. So he had his damage control with pelvic X-fix and debridement and fixator for the tibia. Unfortunately, the leg wound got infected and he presented to us 3 weeks later. These are the X-rays. When we look at the leg, it looked like this. There is circumferential skin loss and there is a necrosed bone, as you can see. And this is a challenging situation now because there is bad soft tissue. And when we do a debridement of the necrosed bone, there is going to be a bone gap. So a thorough debridement was done and we put on a frame on the lateral aspect. You can see that he was left with a residual bone gap of about 20 centimeters. It's a good idea to put a cement spacer in this situation. So this was in 2016. We did not use a cement spacer. He underwent multiple staged reconstructive procedures to get the soft tissue cover, following which is at 6 months follow-up X-ray. You can see that the periosteum is trying to throw some bone out and the infection is controlled. And we started on to do vascularized fibular grafting in this fashion from the contralateral leg and fixed it with an LCP. And he went on to heal well at 2 years. And you can see that the fibula is incorporated well proximally and distally, and the patient is able to weight bear and walk. And the take-home message from this patient is that bone and soft tissue loss in an infected situation needs a team approach. Large bone defects in the pediatric age group, free vascularized fibula is a viable option. Thank you very much.
All right. back for a few more. So next is Dr. Eidelman. Mark's going to talk about chronic sclerosing osteomyelitis of Garrè.
Well, my case about chronic sclerosing osteomyelitis of Garrè. Next slide, please. So Garrè is a really orthopedic enigma, exactly like Pertussis disease. There is no treatment consensus, treatment courses. The patient usually complain. I'm sorry. I'm trying to do my video. Just a moment. I don't know why, but I cannot open the video now. So patient usually complain about progressive pain and disability. There is prolonged and unpredictable course of the disease. I have patients with really mild symptoms that able to take symptomatic treatment, and I observe them, but this is not the case that I would like to share with you. Garrè was described in 1891. I wonder how he, without X-ray, described accurately this syndrome. There is a chronic form of disease in which the bone is thickened and distended, but there is no abscess and sequestra or histologically. Next slide, please. Bone biopsy revealed chronic low-grade osteomyelitis. Cultures are usually negative. There are secondary lesions described at distant site many years after start of the osteomyelitis. Next slide, please. The proposed treatment include decompression, curettage, non-steroidal coquetin, steroids, and observation. This is the standard treatment protocol for years. Next slide. So my girl, that time when I saw her, she was 15-year-old, history of 4 years of pain and swelling of left distal leg, osteomyelitis on CT, indium linked bone scan showed no infection. I did bone decompression that gave just temporary relief for a few months. And she came to my office with mother and asked for amputation because she was unable to suffer the pain. Next slide, please. So if you're looking, there is a 12 centimeter of osteomyelitis, and the only area without disease is just 1 centimeter above the ankle joint. And I hesitated what to do. As I said, the official treatment is observation and symptomatic treatment. Excision was not described for Garrè. Next slide, please. So how many wires you can put in the area below the distal iliac wire? I put 3. Next, please. Next, please. Next, please. So this is the block of the osteomyelitis that I removed. Fibula was intact, of course. Next, please. So there are 3 wires just in the area of the centimeter above the ankle joint, and I kept them for 1 year, exactly for 13 months of bone transport. Next, please. Next. Yes, this is the excision of the block, and this is the proximal tibial osteotomy, bone transport, and standard manual. Next, please. And this is the end results. I achieved the union, of course, this bone grafting at the docking site after 13 months. Now she's a 31-year-old. I saw her recently. She's mother of 3 kids and absolutely normal life. Next, please. This is the first description of bone transport and excision of the osteomyelitis for Garrè. We described it as a case report in GPOB. Rob Rospro, Rob Paley told me that they did the same for Garrè. And I think that this should be done in patients that cannot survive the pain. Next, please. So my take-home message: when conservative treatment in Garrè doesn't work, resection of the lesion is very effective procedure. Thank you very much.
Excellent. Thank you, Mark. I skipped a talk which was recorded, and so we're just going to do Dr. Patwardhan's recorded talk on TB osteomyelitis. Thank you.
Good morning. This is Dr. Patwardhan from Pune, and I'm presenting this case on tuberculous osteomyelitis. 16-month-old baby came with mild pain and swelling around the knee with a little limp. This was his primary X-ray, which did not show much. But in 3 months, you can see a juxtaepiphyseal lytic lesion. His labs were normal, CRP-ASR was normal, but advanced imaging in the form of MRI showed a large soft tissue mass straddling the epiphysis with a suprapatellar effusion. And we decided that this needs biopsy. You can see that lesion across the physis. After debridement, biopsy, and immobilization, the histopathology revealed a tubercular osteomyelitis showing the classic giant cells and granulomas, and the microbiology shown scanty AFP, confirming the diagnosis. Antitubercular treatment was started, and over a period of time, it started healing uneventfully. And to our surprise, at 7 years of age, though you see a small streak there, there was no bar formation or any growth deviation. Another case, a 1-year-old male with a left hip pain and unable to walk for 4 weeks with pseudoparalysis. You can see the osteolytic lesion in the neck region. Again, the MRI shows a diffuse edema as well as soft tissue infiltration in the subtrochanteric region, debridement, biopsy, culture, and spica. Histopathology, again, the diagnosis was tubercular osteomyelitis. In 1 month, you can see the response, and in 6 months and in about 16 months, the lesion is completely healed with no growth sequelae. So you must understand that tuberculosis in India is very common. It follows a subacute course. There may be a delay in diagnosis. The inflammatory parameters, not much change is seen. It may be subtle. Tissue diagnosis is mandatory before we start antitubercular treatment. You must rule out BCG osteitis and pyrazinamide resistance, and newer modalities of drugs may be needed in multi-drug resistant tuberculosis. Refusal to use, a mild swelling, may or may not have fever, a deformity, a lymphocytosis with very mild changes in the WBC, an X-ray finding at 4 to 6 weeks, which is around the epiphyseus or the metaphyseal region with a lytic lesion. MRI will give you early diagnosis. Gledhill and Roberts have classified subacute osteomyelitis, of which TB is a part, into 4 types. You can go through this slide. Keep in mind the differential of Langan histocytosis, PNET, and subacute osteomyelitis of the bacterial variety. It's been published that most of TB in osteoarticular region happens in the third world countries, but the total burden is unknown. Lung localization is seen in 75% cases. Musculoskeletal system is just about 3%. Bony lesions are 4 types: cystic, infiltrative, erosions, or spina ventosa. This series, which was published in JPO, 23 cases of TB osteomyelitis, age between 10 months to 11 years, 17 patients for less than 3. Generally afebrile, mild increase in the lab parameters, CRP are very well within normal limits, and X-ray will always show osteolytic lesion in the epimetaphyseal area. To rule out BCG osteitis, you must prove that it's the same strain, which might be difficult. Expert MTB and RIF methods may be used for diagnosis of extrapulmonary tuberculosis. These are the new tests. And children suspected to have osteoarticular TB should undergo these tests for confirmation. Usually, a 12-month regimen is advocated, of which 4 drugs for 2 months, which are HRZE, and then 2 drugs for 10 months, that is H and R, should be used for treating tuberculosis. The doses have been very well published, as shown here. And you can also read this particular paper from Wadia Children's Hospital in Mumbai regarding a diagnostic and management challenge of osteoarticular tuberculosis. Thank you very much for this opportunity. Over to you, Sanjeev, for more questions.
All right, great. Thank you. Let's just keep moving. So I'm going to get Dr. Dave Spiegel back. He's got a couple of cases, and then we're going to just finish up with the upper extremity talks. So go ahead, Dave. Thank you so much.
Okay, can you hear me?
Yep.
Okay, new slide, please. Okay, this will be a quick one. So 17 years old, having some pain in the proximal thigh, no history of trauma, no fevers. And however, the pain does wake him up at night. New slide. So the plain images, I apologize, plain x-rays didn't show anything dramatic. So the managing team decided to get an MRI and a CT scan. On the MRI, an intracortical lesion, but no surrounding fluid collection. The CT, again, it demonstrating an intracortical lesion, and it was felt to potentially, especially given the history, to represent an osteoid osteoma. New slide. So patient elected not to be treated, but the symptoms were unchanged. And so, as often happens on our side, the lesion was re-imaged. And to my side, it looks like there's a bit more lucency around the intracortical process. Anyhow, so they were scheduled for an IR-guided biopsy. And if the lesion was consistent with an osteoid osteoma, then an ablation. New slide. But lo and behold, pus came out, and it was gram-positive cocci, and so cultures were obtained, and the patient was treated with Keflex. New slide. So I guess it was a period of time, maybe 4 months post-operatively, we ended up getting a relapse of discomfort. So the patient was re-imaged, demonstrating some periosteal fluid and inflammation. New slide. So underwent debridement. The cultures were negative this time, and then was continued on a course of Keflex. New slide. And so ultimately at 5 months on the right side, at 5 months following surgery and 10 months following the initial presentation, there's the radiographic appearance. The patient is asymptomatic. The labs, of course, are normal. And so at least the disease is clinically quiescent. New slide. So I guess this is just another example of keeping in mind, new slide, keeping in mind that the differential diagnosis quite commonly involves differential diagnosis of tumors can include an infection and vice versa. So we always have to keep in mind biopsying infections and culturing tumors. Thank you. Okay, another one. So here we go. 10-year-old female, new slide. So history, injured roller skating, presumptively diagnosed with a fracture, treated as such at an outside institution, then came back to that institution with increasing pain. Labs were elevated. They did a biopsy. Cultures were negative, path consistent with osteomyelitis, treated with Keflex. They were seen by the infectious disease and rheumatologist at that institution, and no improvement in symptoms. New slide. So then presented, referred for another opinion with these x-rays and having some inflammation and swelling in the area and tenderness to palpation and some inflammation over the posterior tibialis tendon. So treated with a cam boot, rest, symptoms improved. New slide. So that was 5 months after the initial presentation. And then, so the patient was doing well for a period of time. And then on the right side, that's 3 months after presentation, the pain was increasing. The SED rate was mildly elevated. There was a few degrees of distal tibial deformity. New slide, please. So got a new team of specialists involved and discussed options and decided just to start over and just repeat the biopsy. And so as for the first time, cultures were negative and the path was consistent with infection. Next slide. So then treated with, for analgesia, treated with anti-inflammatories with rest, the symptoms improved. We finally got the patient to see rheumatology. They recommended a whole body MRI. Next slide. Here we are 13 months later. Next slide, please. So now we're 13 months after, still haven't gotten the MRI, but clinically quiescent. You can see that the radiograph is improving. Next slide, please. And so here we are finally at 25 months following the initial presentation to an outside institution, or I apologize, 30 months following the initial presentation, 25 months after we saw the patient, couple of degrees of valgus, finally got the MRI, was pretty unimpressive with the exception of some proximal tibial increase signals. At this point, clinically doing well, but awaiting following up with rheumatology. Next slide. So I think the main point here is that non-bacterial osteomyelitis, or what had been called, multifocal recurrent osteomyelitis, can occur in one site, or it can occur in multiple sites, or, one or more sites can be symptomatic. But we definitely have to keep it in the differential diagnosis of acute hematogenous osteomyelitis. And because we have culture negative acute hematogenous osteomyelitis, and we've also got non-bacterial. And so it's an inflammatory disease process of bone, and the management is different. The first line is with anti-inflammatory agents, nonsteroidal anti-inflammatories. But if that's not sufficient to control the disease process, then other lines of treatment, including methotrexate and other agents, are utilized. So I would also say, keep in mind, it seems from doing a little research that the image of how the physis looked is kind of a characteristic radiographic appearance of this disease process. So at least keep the x-rays in mind and keep the diagnosis in mind. Thank you.
Excellent. Thank you, Dave. Those are great. So it's a nice segue because now we're moving to upper extremity, but we're still going to do another case of non-bacterial osteitis or osteomyelitis. So Dr. Sunil Wijayasinghe is going to come back and present that case. Go ahead, Sunil. Thank you.
Yeah. Great. So we are moving to another type of osteomyelitis. So it is close to the midnight of this part of the world. Next slide. So it's a 15-year-old girl who came to us from a local hospital with gradually worsening pain of the right upper arm. And then that child was so symptomatic that she had pain throughout the day, affecting her daily activities, including her schoolwork. And this pain was not related to any trauma or any febrile event. Next slide. On examination, there was swollen, tender right upper arm. It is restricted active and passive shoulder movements with no other joint swelling, and there was no distal neurovascular deficit. Next slide. We did all the investigations. Only things which we found was marginally elevated ESR and CRP and alkaline phosphatase level, and rest of the biomechanical and the hematological investigations are normal, as you can see in this slide. Next one. When we did the plain radiograph, it's very, very alarming image. There's a destructive upper diaphyseal lesion in the right humerus that you can see it very clearly with a cortical breach and soft tissue involvement. Next slide. And CT and MRI showed a large destructive lesion, and with a lamellated periosteal reaction with cortical breach and soft tissue extension with no similar lesions elsewhere, which was highly suggestive of Ewing sarcoma according to the radiologist report. Next slide. So we did histopathological assessment, and it was the first biopsy was a needle biopsy, which was not keeping with clinical and imaging findings. It was first biopsy was, of course, it was not in keeping with Ewing sarcoma, and therefore there was a request to do the rebiopsy, and we had to do an open biopsy at that time. But both biopsies showed arcades of cortical bone with trabecular and normal cellular bone marrow, and there were no atypical cells or malignant osteoids in both biopsies. Next slide. And you can see the slides here in this child. There's a mature cortical bone trabeculae surrounded by soft tissues, fibrous tissue, and only chronic inflammatory infiltrate were present. Next slide. So the management there was no specific management. It is symptomatic treatment. Specifically, when there was pain, we treated this child with naproxen, and then closely followed up with the symptomatic treatment. And over the period of 3 years, we showed significant improvement of symptoms with no pain or deformity. Next slide. Mm-hmm. So this is the X-ray after 3 years. You can see the lesion has drastically reduced in size with almost normal bone contour. Next slide. So you can see the comparison on your right-hand side, the lesion at the beginning and now 3 years later. Next slide. So the take-home messages from this case, the diagnosis of chronic recurrent multifocal osteomyelitis should be made in combining your clinical, radiological, and histological findings. And at times, like in this case, arriving at a correct diagnosis is extremely difficult. However, it is important to correlate all in order to arrive at a correct diagnosis to avoid unnecessary antibiotic treatments and surgical interventions. Thank you very much.
Excellent. Thank you, Sunil. And again, I really appreciate everybody hanging on. We've got still 156 participants, and I think a lot of them are attending past their bedtime, as are a lot of our faculty. So I really appreciate that. So Dr. Spiegel's going to come back for his last talk. Thank you, Dave. Go for it.
Okay, so next slide. So again, this is going back to some of the earlier talks. Here's a very young child, febrile, quite sick, really high inflammatory markers, septic, MRSA, MRI, obvious osteomyelitis with coexisting septic arthritis. So went to the OR, had the shoulder washed out, a corticotomy in the humerus, and then was started on very strong antibiotics and did well clinically. Laboratory studies were coming down and was discharged on oral clindamycin. Next slide. Okay, so then the child fell and got a pathologic fracture and so was placed into a splint. Next slide. So then time's moving forward. The radiograph shows obviously the displaced fracture, but it looks like there's some early healing present. Clearly there's involvement of an extensive area of the humerus. The fate of the physis is unclear, but the patient's doing well and the labs are normal. Next slide. So time is moving forward until we get increasing pain and back in the emergency room, reimaged, large abscess, repeat involvement. So IND is performed once again. Went back through the course of intravenous followed by oral antibiotics. Rifampin was added as, I guess, a force multiplier. New slide. Okay, so now here we are. The patient's been maintained in a brace. The laboratory stuff is okay. The patient's clinically doing okay. Question is, what's happening here as far as the healing goes? So we're following the patient along, and it doesn't look so good at 3 months after surgery. New slide. So there we are at 5 months after the initial surgery, what appears to be hard to argue that that's not a chronic or a non-union. So now what? Next slide. So we took the patient back and did a debridement back to punctate bleeding. We put a cement spacer in there and we put the patient in a shoulder spica cast, and we left this on for 6 weeks. New slide, please. And then took the patient back. We looked in. I don't remember if we did a frozen section, but that would have been a good idea. Everything looked clean. There was a nice rim of, I guess you'd say, induced membranes were present. So we decided to do iliac crest bone graft and plate it. New slide. Continuing to protect the patient. There's 10 weeks post-op. Things are heading in a positive direction. New slide. 4 months post-op. New slide. And here we are at 6 month post-op, and then I guess it's still asymptomatic 15 months after. It appears that we have, I hate to ever say, I don't think we can ever say that we cure osteomyelitis, but I would say that really looks like we've had good disease-free survival and we're hopeful for the future. New slide. So I guess I didn't have many useful points that you haven't heard from before, but thanks once again for your attention and for the opportunity to participate.
Very nice. Thank you, Dave. All right. Next, I'm going to introduce Dr. Faseeh Shahab. Faseeh is from Pakistan, Peshawar, and he's a medical director and assistant professor at the Shahab Orthopedic Hospital in Peshawar. And he really does a lot of different things. He's got a broad practice. And I think he's one of the largest sign nail user as well. And he comes frequently for these courses, including the IGOT and the SMART and the sign courses as a faculty. And he was also part of the faculty in Tanzania last month. So Faseeh's going to present a case of osteomyelitis sequelae upper extremity. Thanks, Faseeh.
Thank you very much, Sanjeev, for the opportunity and for making a wonderful program. Next slide, please. Next slide. So I will talk about a case of 6-year-old girl who presented with a progressive right arm pain to her GP initially, and she presented with the history of fever for the last 3 days. So she was initially treated with oral antibiotics, and as is a very common case, once the fever subsided, the pain subsided, so they just left the antibiotics as it is. And then after stopping the antibiotics, she developed pain and fever improved, and then but then she developed cough. Next slide, please. So with the cough progressively worsened, and there was an increase in feverish episodes. And as they say that the chest X-ray predates by about a week of the pathology that's going on. So although her symptoms were getting a bit better, but her chest X-ray started deteriorating. She was started on IV antibiotics. Next, please. And after a course of a week or 10 days, her chest symptoms subsided and her fever improved. Next. But once the therapy was stopped, she again started pain in her arm, and for which she was given a backslap for pain control. Next slide, please. The next available record was that after 6 months of her initial presentation to the hospital, she underwent surgery for osteomyelitis of her right humerus, for which debridement was done and drilling was done in the proximal metaphyseal area. And then sling was advised for her for on and off pain for pain relief. Next, please. So after 3 years, she presented with a stiff elbow. There was no pain. There was no infective sinuses, and her infection markers, that's all ESRCR, PWBC, were all normal. Next slide. And now she presented. She basically presented last month. And this is her current clinical picture. So she has a stiff elbow, and she has a gap non-union of the proximal metaphyseal area, the area for which bone drilling was done initially. Next slide, please. So now she has a very good range of motions, but she has a non-union. Her internal external rotations are restricted. Her elbow range of motion is fixed at 90 degrees, and she has good flexion and extension at the shoulder joint. Next slide, please. So now we have two options. The first option is the biologically, we reconstruct biologically with fixation and length restoration. And on second option is to leave her as such and observe over time. The main aspects in decision making, the challenges are that she has stiff elbow joint and shoulder joint, and if we fuse the only site where there is more motion, it risks the loss of function of the patient. So we have to balance the functional and radiological outcome. So the take home is, and this is something that I would like the panelists to answer, what would they think would be a good idea for this. The take home messages for this case is that we have to balance the functional and radiological outcomes. The persistent limb pain after stomach infection should never be ignored. If the delayed or incomplete treatment results in chronic osteomyelitis and deformity, the functional outcome is as important as radiological union, and reconstruction decision must balance surgical risk with existing adaptation and function. Thank you.
Thank you, Faseeh. I hope we'll have a minute or two to discuss this, but let's move on to the last two cases. Next is Emeka. He's going to talk about treatment of post-infected bone defects in the forearm. Go ahead, Emeka.
Okay, yeah. So I'll be presenting a post-septic right forearm bone loss. My patient is a 13-year-old female with residual right ulnar bone loss following chronic osteomyelitis in early childhood. She's a right-hand dominant, but performs most of the demanding chores with the left hand. There was progressive migration of the dislocated radial head that causes visible deformity, elbow instability, and constant impingement pains. On examination, we ascertained good range of movement in the humero-ulnar articulation based on a small residual proximal ulnar articulation, the humerus. Next. So the options of treating this patient were, we consider synostosis of the proximal ulnar remnant of the radius to create a single bone forearm. Another thing was excising of the impinging proximal radius, at least to deal with the impingement pain. And induced membrane musculae has been discussed extensively during the course of these talks. Gradual distraction with ring fixator and synostosing radius to ulnar, and fibular strutting of the defect and bone grafting. But we thought, because of the engineering nature of the patient and the complexity of the various options, we thought of the most feasible, simplest means of treating her and giving her some function and some cosmetic improvements. Next slide. So this a diagram of the deformity. Next slide. So we made an osteotomy in the middle of the radius and pulled it down. It was osteomized and proximal fragment was pulled down until the radial head was at the same level with the capitellum. Next slide. At the point of overlapping with the distal fragments, made another osteotomy so that we have an intercalaric fragment of bone. Next slide. We also freshened the remnant proximal ulnar and then the distal part, salvaging the chippings we removed as feature grafts. Next slide. So we subsequently used the intercalaric fragments we removed from that bone, used it to bridge the defect in the ulnar, which solves the problem of the bone gap. Next slide. Okay, next slide. So this was what we did. We now plated the residual radius and then passed a wire, a Kirschner wire, down through the residual ulnar, and bone grafted the areas in which they bridged the bone gap. Next slide. So this was what's happened eventually with the plating and then the K-wire. And it went on to heal very well without any problem. Apologies, this was done without CRM, so the proximal, the K-wire did not stay in the lumen. It just penetrated the wrist, and that caused a little pain for her. Next slide. So the result was a good and stable elbow, full elbow and forearm range of movements. The impingement pain was gone. Deformity was corrected. She now uses the right upper limb much more. But the problem is that there was still relative shortening of the left forearm compared to the right, which she didn't really bother about. And then she complained intermittently of pain from the Kirschner wire in the wrist region, in the wrist area. But this will be taken care of when we remove the wire. Next slide. So the take-home message here is that post-infective forearm deformities, segmental bone loss can produce significant limb length difference, pain, and the deformities. The main objective is to improve functionality and reduce pain. Even simple approaches can sometimes help to improve these deformities. Thank you.
Thank you, Emeka. And that was a great case. Last one, and we're right on time. So, Mohan, can you do this in 5 minutes or less?
Sure.
All
right. Thank you.
Okay, go for it.
So the next slide, please. So the initial history is somewhat similar to the previous patient. So she had osteomyelitis when she was younger, around the age of 1 to 2, and had initial treatment, medical treatment. Later developed sequestrum, and she was treated for it in a medical camp in the Republic of Congo, where the middle segment of the ulna was resected. And she then migrated to the United States like 7-8 years later. She presented to our clinic when she was about 10 plus 9 years old with not much pain, but essentially progressing deformity of the right forearm and a weak grip with restricted rotation in a forearm as well. Next slide, please. On examinations, we found that she had a shortening of a couple centimeters of her right forearm with significant manus varus deformity and radial bowing, and increased ulnar inclination of the distal radius, as well as restricted pronation, supination, but reasonably good flexion extension at the elbow, as well as at the wrist. But she had an anteriorly dislocated radial head, but it was not impeding elbow range of motion. She had decreased grip strength compared to the other side, about 30%. Labs were all normal. Okay, next slide, please. And this was her clinical picture. Next slide, please. Then you can see here. So what had happened was, because of the pseudarthrosis, where she had resection of the middle part of the ulna, the ulna was not growing appropriately, and gradually over time had developed a deformity in her forearm because of the parallelogram effect, and this had caused dislocation of the radial head anteriorly and superiorly, as you can see here, and that was impeding range of motion. Next slide, please. So at this time, the problem list was post-infective chronic pseudarthrosis of the ulna with forearm deformity, radial head dislocation, an arm length discrepancy, and restricted forearm rotation. So the treatment options were either leave her alone, but the deformity would continue to progress as she continued to grow, and then or do a reconstruction. But the problem was the distal segment of the ulna was not big enough to do any kind of reconstruction, either non-vascularized or vascularized, or even a non-vascularized fibula graft like you've heard before. And then the last option, because she already had significant restriction of range of motion, was to create a one-bone forearm. Next slide, please. So after discussing with the family and also the plastic surgeon, then we decided to go ahead with the one-bone forearm. So this is what we did. So we then identified the middle segment of the ulna as shown there, resected the radius, and created a synostosis between the ulna and the proximal part of the ulna and the distal part of the radius. We used the proximal radius as a bone graft, kind of pinning bone graft to increase the strength. Next slide, please. So we were able to correct her forearm deformity while maintaining elbow and wrist range of motion. And then she healed pretty much nicely. This is a follow-up at 2 years, and she's functioning well at this point. So next slide, please. So the take-home points are, chronic osteomyelitis of the ulna with pseudoarthrosis can cause a progressive deformity because of the differential growth of the two bones in the forearm and the parallelogram effect, resulting in a bowing deformity of the radius to start with and a radial head dislocation later on. And that can affect both forearm as well as elbow range of motion. So early reconstruction of the ulnar bone defect is important, and where it's not possible to reconstruct the bone defect or where the forearm range of motion is significantly affected, then you can consider a one bone forearm procedure. Thank you.
So good. Okay, so you've got 5 minutes, and then I think we can go maybe overtime another 5 if that's okay with everyone, if that. But yeah, let's just very quickly, this is going to be very abbreviated. Yeah, go to the next slide, please, Mary. Yeah, so, this section was on the miscellaneous stuff, non-bacterial osteitis, and then, can the faculty open up their videos or at least their mics or speakers? And so anybody can take any of this on. I know Faseeh had a question about that unresolved case with a post-septic bone loss of the proximal humerus and a fused elbow. Faseeh, was she having any pain or not?
No, she doesn't have any pain. She has good range of motion at her fractured the non-union site. So the question is to restore the alignment and to have a bony union, we would risk the movement that she has currently. So because she already has a stiff elbow and her shoulders is most likely fused as well.
Okay, Mohan's got his hand up. And by the way, is this dominant, non-dominant? Do you know?
This was dominant, but for the last 5 years, she's been using the other side. So now it's non-dominant hand.
Okay, all right. Mohan, I think you had your hand up, did you?
Yeah, I had the same question as you did, whether it was the dominant side or the non-dominant side. But given that she already doesn't have any movement in her elbow, and we don't know what's happening with the shoulder, possibly restricted, if the risk would be of losing all movement and deteriorating function. So I would probably not do anything.
Yeah. That sort of was my gut too, but see if anybody else feels differently. This whole thing of, form versus function. So I think for the most part, function goes first, takes a higher order. We, saw a few cases of non-bacterial osteitis. It's an enigma, but I think you need a biopsy for one of those to be diagnosed as, diagnosis of exclusion. And I don't know if we have time to really discuss it, but I think in some ways the principles of upper versus lower extremity post-septic, deformities is different. Like this last case with the proximal shoulder, if that same thing was happening to the proximal femur, I think our answers may have been slightly different, right? So just food for thought. Okay, let's go to the final take home, which is, again, like, Dave and others have said, biopsy infections, culture tumors. Like you heard from Dr. Hitesh Shah and others, that anti-TB therapy, high index of suspicion, especially with the metaepiphyseal lesion and the, more where TB is more common, and even if it's less common. The good news is that you don't need much surgery other than to make a diagnosis sometimes, and just long-term anti-TB treatment is the mainstay. And then there was a nice talk on osteoperiosteal fibular graft, by Dr. Venkatadass. And so I think that's a great technique. And you've seen other techniques during the whole webinar, where I think, you could sort of keep it in your armamentarium so that, you may need it at some point. And, use clinical diagnosis, judgment, That's so much more important than just looking at an image or just looking at a certain protocol or standardized thing. And I think what the beauty of today's webinar, at least for me, was that we saw a lot of creative, simple approaches that were based on sound principles. And this was the last thing was, I think I heard from Scott Nelson, but others have used it too, that when you're faced with situations, irrespective of resource availability, you could certainly improvise, but don't compromise on the principles. So let us, anybody has final thoughts? We'll just go to the final.
Dr. Brent-Scott has his hand up.
Oh, yes, Vivek, please.
I have a question, actually. I recall one case in our hospital. A young girl who was being treated for chronic osteomyelitis of the proximal tibia for months and months together. And at some point, her biopsy turned out to be a squamous cell carcinoma. So this, we've been taught that, they can transform. So I just wanted to hear, everyone's thought on this, because, it can be a real big whammy for the patient. And are there any red flags? I think Dave really highlighted the importance of biopsying. So I just wanted to bring this up while we talk on this subject.
Yeah, like you're right. So, squamous cell carcinoma, draining sinuses, Marjolin's ulcer. So yeah, go ahead. Anybody wants to tackle that? Like, when should you have an index of suspicion that this is not just an infection and it's now, some kind of a malignancy, maybe secondary? Anybody has experience with that besides Vivek? You've seen a Marjolin's ulcer or a squamous cell carcinoma? But I mean, it's been well described, Vivek. So I think if isn't a chronic draining sinus like one of the precursors to squamous cell carcinoma in these situations? Like, did this patient have a draining sinus or was it dry?
I think the wounds just refused to heal. That was one of the things I recall from this case. But I guess, every time you take a patient in, you just make sure you send a biopsy. That's, I just wanted to hear everyone's thought. And, because it's so uncommon, it's sometimes, you might end up overlooking it and just end up in a soup. So,
yeah.
Go
ahead.
If the discharging sinus is more than, 10, 15 years, be aware there is a possibility of squamous cell carcinoma. So we have seen cases where they've been discharging for more than 15 years and they come with something which looks more, aggressive now. Then you start looking for a biopsy. But it doesn't happen I have not seen it in less than 10 years, no.
The 10 years duration of chronic drainage. Is that
sorry, my video has been off all the time, so I couldn't.
No, you're good. Matthew, we heard you. That's great. Okay, and I thought Gamal had his hand up, or is it okay now?
Yes, it's okay.
All right, good. All right.
I had two cases.
Yeah, go ahead, please.
I had two cases. One was infected ununited humerus, which was treated by plating. And I noticed during the operation that I have, necrotic tissue. Necrotic tissue. It's not the bone, it says. And I made the biopsy, and it was carcinoma. And they had the 4-quarter amputation afterwards. 2 weeks afterwards, after the oncologist was sure of the diagnosis or something. And I had another tibia also. And I noticed the same thing. And, and it was bone transport. I did bone transport. Anyhow, it was wrong diagnosis, and it went well afterwards. It was not carcinoma or something, after further investigations, and there was no problem. So actually, it's a real case. It was infected humerus, which proved to be carcinoma.
Yeah. Was there like a growth, Gamal, or just you?
Yes, it looks like, necrotic tissue. It's, I'm doing, infected non-union day and night. This is a regular case. We can do 4 or 5 per list. But for this case, the necrotic tissue was massive. The soft necrotic tissue was more than the bone problem or something, which I noticed, it looked like it's never ending. When you remove, there is more and more and more. And it was proven in oncologists by 2 pathologists, and they did 4-quarter amputation 2 weeks afterwards.
Okay. Well, thanks for sharing. Sad outcome. Okay. All right. Let's go to the next. So just closing remarks, and really a big, huge thanks to everybody. But let me see what the next slide says. All right. So what's next? So I know we've had a long half day. And again, thank you, everybody, faculty, participants. We still have about 145 that are online. That's great. So please take a picture of this QR code. We really need this because I know there's stuff we can improve. And like this year, we did it on a Saturday based on your feedback from past. And we did these, quick cases, partly based on the, partly based on the feedback. But I don't think we've arrived yet, so we'll keep tweaking it. We also want to know what to cover next year, and also, ideas about the format, what you liked, what you didn't like. And, you can be very brutal and honest about it, but let us know how it went. And for all participants, you will get a certificate of attendance. Within the next 2 weeks, it'll be tied to the survey. So please respond to the survey and you'll get the certificate right away. And as I said, give us feedback of, what we can do differently for next year, what topics. And if you want to reach out to one of us at the UCSF Limb Differences Program, you can use that email. And next slide, Mary. Really a big shout out to all our faculty. You were awesome. Really, everybody was so awesome. People who came, went, stayed for the entire thing. And again, I really appreciate that it's past midnight in some parts of the places you're at. So great job. And hopefully, most of you will come in next year. And the one person I didn't acknowledge because she didn't have a case, but Colleen, thank you. You were doing behind the scenes very beautifully today. So Dr. Sabatini is one of my partners. She's the vice chair of health equity and a professor of orthopedics here at UCSF. She too has won a bunch of humanitarian awards, including from POSNA, the Academy. She is the co-chair of IGOT and, spends a lot of time overseas. So Colleen, thank you so much for handling the back end. And finally, I think there's one more slide or not. Yes. So, this is really the first and the last slide, I guess, but I truly mean it. And please, everybody who can, just give them a big round of applause. Definitely the top 3 who sort of have stuck with me for a long, long time. So thank you, Mary, Bridget, and William, and everybody else. And of course, Ranjit, I can thank. I'm not going to be able to thank her enough. But again, thank you so much. So please give us your feedback and have a good rest of your weekend. Enjoy soccer, basketball, whatever else you want to do. So great. Thank you. Anybody else wants to, anything else you want to say? Anybody? Faculty's good?
Just thank you for your incredible organization of this wonderful annual webinar, Dr. Sabharwal. Excellent, excellent work. This is such a phenomenal group of people to have together and be able to hear their experience and their perspective. So thank you for making this happen.
Thank you. It's years and years of friendship. So yeah, let's keep it going. All right. Take care. Bye-bye, everybody.
Thank you, Sandeep.
Bye.
Thank you,
very much.
Sandeep. Bye.
Thanks, everyone. Yeah, bye, everyone. Thank you. Amazing.
Bye. Thank you.